Hello, everyone. My name is Nathan. I'm a fourth year pharmacy student, PharmD candidate of 2024. Today, I'll be doing a topic discussion on mechanical ventilation that can be used in the surgical ICU and medical ICU at Providence and Everett. Thanks. So, for this topic discussion, the goal is to answer some basic questions regarding mechanical ventilation so that we can get a better understanding of what it is, how it's done, and what the pharmacist's role within it is. So to start, we're just going to answer, what is mechanical ventilation? When is it indicated? Then we're going to go over what are the different parameters of mechanical ventilation, what are the different modes of mechanical ventilation, and how is it actually weaned off. Next, we'll just go over briefly some non-invasive ventilation methods. And then lastly, we'll go over the complications of mechanical ventilation and what the pharmacist's role is in preventing or reducing these complications. Okay, so briefly, to answer the question, what is mechanical ventilation? Mechanical ventilation is a form of an invasive life support. It uses a ventilator, which is the one you can actually see over there on the left. That's actually the ventilator used at Providence and Everett. And this ventilator is used to either fully or partially provide artificial ventilation support. So what are the indications for mechanical ventilation? Basically, it can be boiled down into a single primary indication of an inability to maintain adequate alveolar ventilation, which essentially means the patient doesn't have the respiratory drive or capacity to properly ventilate on their own and require the support of a ventilator for their respiration. Some indications here are listed below. Some ones of note could be like acute respiratory distress syndrome, severe pneumonia, a neuromuscular disease such as myasthenia gravis, shocks like cardiogenic and vasodilatory, and different types of traumas like acute brain injuries. There are two basic forms of respiratory failure that could possibly indicate the necessity of mechanical ventilation. First would be hypoxic respiratory failure, which would be the progressive and worsening hypoxemia or a low arterial oxygen pressure. Next would be like hypercapnic respiratory failure, which is an inability to blow off CO2, which leads to increasing arterial CO2 pressures, leading to respiratory acidosis. So next we're going to be going over some of the parameters that are commonly seen with mechanical ventilation. These are typically going to actually be seen in some of the order sets, and in fact actually at the very end of this presentation I'll go over some example orders. So it'll be good to kind of memorize and learn what these actually do mean, because they're also important in the different modes. So to start, you have your basic tidal volume. Your tidal volume is the volume of air inhaled or passively exhaled in a normal respiratory cycle. You can just think of it as basically the volume of air going in during each breath. It's used to maintain adequate oxygenation and CO2 levels. Typically, a tidal volume is set at around 5 to 10 milliliters a kilogram by ideal body weight. You'll typically see tidal volumes of around like 400 to 700 mils or so. Next, you have your respiratory rate. That is fairly self-explanatory. It's a preset number of tidal volumes patient will receive in a minute. So you'll see it indicated as breaths a minute. It's used to optimize the arterial CO2 pressures as well as the pH. So it's a way to actually blow off some of the CO2 in a respiratory acidotic setting. Patients with normal physiological lungs or obstructive lung disease, typically you'll see a respiration rate of 8 to 15 breaths a minute. If patient has some form of restrictive lung diseases, it might be around 15 to 20 breaths a minute. But really it can range anywhere from around 8 to 20 or so. Then you have flow rate, which is indicated as liters a minute. This is the volume of gas per minute that is achieved with the mechanical ventilation. It determines the inspiration-expiration ratio, which is indicated as IE. Normal inspiration-expiration ratio is 1 to 2, but it can actually get inversed and go up to around 4 to 1. Flow rate typically is started around 40 to 60 liters a minute. For the IE ratio, it is basically how much volume of air, how much time is spent during the inspiration phase versus expiration phase. So longer inspiratory times allow for more alveolar recruitment and ventilation. Basically, you can think of it as the oxygen is in the lungs longer, so it can diffuse over a longer period of time, and that is what would be seen in the 4-to-1 ratio. Next is the fraction of an inspired oxygen, also called FiO2. This is the percentage of oxygen being delivered to the patient during each breath. This ranges from 21 to 100%, although typically the lowest FiO2 that can be done on a mechanical ventilation setting is going to be 30%, because 21% is actually what we breathe in normal air. Right now, you're breathing 21% FiO2. And last is the positive end expiratory pressure, also called PEEP. This is the holding pressure in the lungs during expiration. You can kind of think of it as, so it's the lowest pressure achieved during mechanical ventilation, and it can be thought of as like when you blow up a balloon and let out some of the air, but you don't let out all of the air. The pressure inside that balloon is the PEEP at its lowest. So higher PEEPs increase the surface area of the alveoli. So think of the balloon. If you're not letting as much air out, the balloon is bigger. It has more surface area, and that leads to recruitment of alveoli and improved oxygen diffusion. The issue with higher PEEPs, though, is it can lead to increased cardiothoracic pressure, so there are downsides to high PEEP. So next we're going to go over some of the basic modes of mechanical ventilation. I'll go over 3 basic modes. There are a lot of different modes that are associated with mechanical ventilation. Some are very complex, but I'll go over the most commonly used modes. So first is going to be control mode ventilation, or CMV. The preset settings, so once again, this is why those parameters are important. The preset settings in CMV are tidal volume, respiration rate, FiO2, and PEEP. This is a volume-controlled setting, which means there is a set volume delivered to the patient every certain number of seconds, depending on the respiration rate. The patient in CMV is not able to generate their own tidal volume breaths. So the only oxygen being delivered to the patient is that set rate of volume of air. Some of the downsides, so if the patient has a lack of sedation or is under-sedated or is going through a sedation interruption, it can lead to air hunger and agitation, because as you can imagine, if you are awake and not able to control your own breathing, it's going to be very uncomfortable. And it also it's not going to allow for weaning, because the patient is not doing any respiration on their own. However, some of the benefits is it is a fixed volume that can be easily titrated based on the patient's need. So if the patient is fully sedated, it's actually very useful in terms of finding that perfect volume and titrating it to help that patient recruit back the lung alveoli and get their strength back. It is typically used for patients who are unable or not required to breathe spontaneously. Next is assist control. It has the exact same preset settings as CMV, so your tidal volume, your respiration rate, your FiO2, your PEEP. And once again, just like CMV, there is a preset volume of air delivered to the patient at a constant rate. However, this time, the patient is allowed to self-generate additional tidal volume breaths. Each breath that the patient tries to self-generate, the full tidal volume of air will be delivered to the patient. So you can think of it as a patient-triggered breath that is ventilator controlled, if that makes sense. Some of the downsides is this can lead to excessive ventilation. The patient will be getting a full tidal volume every time they try and take their own breath. This can lead to some respiratory alkalosis. However, the benefit is the patient is allowed to generate their own breath. So they're using their own lungs. Next, we have synchronized intermittent mandatory ventilation, also called SIMV. Just like the previous two, once again, we have tidal volume set, respiration rate, FiO2, PEEP set. However, this time we actually get a new preset setting called pressure support, which I'll go over in a second. So just like the previous two as well, we have a preset volume of air delivered to the patient at a constant rate. The patient is allowed to self-generate spontaneous breaths. However, unlike assist control, which is patient-triggered ventilator-controlled breathing, spontaneous breathing, this is patient-triggered, patient-controlled spontaneous breathing, which means the patient is going to determine the tidal volume that they get on their spontaneous breath. So they're not going to be administered the full tidal volume. The SIMV utilizes the pressure support to aid in the patient's spontaneous breaths. Pressure support can be thought of as it's very difficult to breathe through an ET tube. It's a tiny little tube down your throat, so it's not very easy to actually breathe out of, as you could imagine. Pressure support aids in giving additional pressure to the breath so that they can overcome the ET tube, making it easier for the patient to do these spontaneous breaths. Some downsides, just the same as assist control, you have the hyperventilation risk. Benefits, it is used as a bridge to spontaneous breathing trials and extubation because it allows for the patient to generate their own breaths and own volume of breaths. So kind of to recap, what is really the difference between these? If a patient is not generating their own breaths, there is absolutely nothing different between these three settings. Nothing. The patient will be given the preset volume of air delivered at a constant rate. However, if the patient is able to generate their own breaths, assist control is going to give the patient a full tidal volume during these spontaneous breaths, while SIMV is going to allow the patient to generate their own breaths and own volume of breaths in each of those. So those are the three basic modes that you should understand for mechanical ventilation and most commonly seen. So we just spoke about how SIMV is a bridge to extubation. So how is the weaning process actually done? So once a patient's on SIMV and it's determined that they can move to something called a spontaneous breathing trial, they need to meet 4 criteria. The 4 criteria are as follows. So you need reversal or stability of the underlying respiratory disease. The patient has to have adequate oxygenation on SIMV, so a PaO2 FiO2 ratio above 150 to 200 or so. Their PEEP has to be down to around 5 to 8. It can't be at a high PEEP. Their FiO2 itself should be below 40 to 50% or so. And their blood gas pH should be above 7.25, so they should not be acidotic. They also need to be hemodynamically stable. This does not mean that they can't be on pressors. It just means that their pressor doses have to be small and they are hemodynamically stable, so they're not fluctuating. And then they also have to have the ability to generate adequate inspiratory effort. So once again, think SIMV. That's why SIMV is a good bridge to extubation, because you're able to see that the patient's able to generate their own inspiratory efforts. So briefly, what is an SBT? An SBT is either like a very minimal ventilator setting, or it's a CPAP, and I'll go into CPAP and BiPAP in a second, but it uses minimal ventilator settings, so the PEEP's at 5, the pressure support's low at 5 to 7, because once again, you are breathing through an ET tube, so you need some pressure support. And there are no controlled breaths being delivered to the patient. And typically, spontaneous breathing trials are done, once a day or so, a couple times a day. They can be 30 minutes to a couple hours. Typically, they'll start off at 30 minutes and then move, increasing in time until the patient basically fully passes an SBT and is able to be extubated. So if a patient is able to maintain adequate oxygenation and respiration during this SBT, they are proving that they can likely be extubated. And that is how the ventilator is weaned. So continuing the topic of extubation, once someone is typically extubated, they'll be placed on a non-invasive ventilation strategy. These 3 are the most common. So first you have CPAP, which is continuous positive airway pressure. As the name sounds, it provides a continuous positive pressure ventilation. You can think of it very similar to PEEP. However, instead of being administered only during expiration as PEEP, it is being provided continuously. Next, we have bilevel positive airway pressure, or BiPAP. Much like CPAP, this provides a continuous positive pressure ventilation. However, this time it cycles between two different pressures. You have your inspiratory pressure and your expiratory pressure. Your inspiratory pressure is basically considered your pressure support, so helping you breathe out. Your expiratory pressure is considered your CPAP level, so your basic low PEEP pressures. And then last, we just have high flow nasal cannula, which provides oxygen at a set FiO2 to the patient at a set rate. It can be up to 60 liters a minute, and it can also be humidified and heated. All three of these mechanical or non-invasive ventilation strategies do require ICU level of care because the patient is still at a risk of reintubation and respiratory collapse. So it requires a high level of care. So last, we're going to go over some complications associated with mechanical ventilation, and this is where the pharmacist plays a large role in the care for these patients. So it's very important as pharmacists. First, we'll go over what everyone thinks of first with mechanical ventilation, which is hospital or ventilator-acquired pneumonia. This is briefly a pneumonia that occurs at least 48 hours after hospitalization or intubation. And the pharmacist is going to play a large role in the care for these patients. So they can do daily infectious disease workups, so, following fever trends, white counts, imaging, if there are any cultures that are done. Because typically these patients are going to be started on broad spectrums, so cefepime and Vanco, so obviously de-escalate as possible. Next, we have gastrointestinal complications, so stress-induced ulcers. When reviewing these patients daily on the floor, you can kind of think of, if the patient's mechanically ventilated, is SUP prophylaxis warranted? Do they have any other risks, or are they coagulopathic? Are they enteral feeding, so maybe they don't necessarily need SUP? These are just kind of questions that you can ask yourself daily as you work up these patients who are mechanically ventilated. Last, we have cardiovascular complications or compromise. So positive pressure ventilation can decrease cardiac output. If you remember back when I was going over the parameters when I mentioned PEEP, at high PEEPs, the cardiothoracic pressures are high, which can reduce cardiac output. So some of the questions you can ask yourself when looking at these patients is, is this patient requiring pressors or inotropic support? Can this support be optimized? Are they experiencing arrhythmias from this support? These are just questions that you can ask yourself when looking at the patients. And lastly, and probably most importantly, is sedation. So these patients are typically going to be sedated. And if they are, is this sedation appropriate? Do they have proper analgesia as well? Can this sedation be weaned, to help pushing towards extubation? Because if they're, on high-dose propofol and it's not getting weaned off, how is this patient going to be extubated? There's also things known as spontaneous awakening trials that can happen during SBTs. So it's a brief pause in sedation and analgesia to see if the patient can, appropriately manage their SBTs. And lastly, if the patient's on like a Nimbex strip, they're being paralyzed, we have to make sure that they have optimum sedation. We don't want them awake when they're paralyzed. So these 4 things are the big areas that we can look at as pharmacists for patients who are mechanically ventilated. So for the very last part of this topic discussion, I wanted to kind of give some examples of what some mechanical ventilation orders might look like in EPIC. My hope is that with all the information given during this topic discussion, you should be able to kind of decipher these medication or ventilation orders and kind of get an idea of where the patient is at with their mechanical ventilation. So I have 2 fairly similar but also quite different examples. So for the first one, it reads, adult cycle volume, mode AC, VT 500, respiration rate 16, titrate FiO2, PEEP of 12. So to break it down, this patient is on volume control mode, assist control, being delivered a tidal volume of 500 mLs at a rate of 16 breaths per minute, with titrating the FiO2 to SpO2 above 92%. They're on a PEEP of 12. So this is maybe an order you might see in someone who just got intubated, right? They have a higher PEEP. They're on an assist control mode. They're not quite able to control their own volume of breaths, but they are able to maybe breathe a little bit on their own and get delivered the full volume. For the second example, we have adult cycle volume mode SIMV, VT 650, respiration rate 12, titrate FiO2, PEEP of 8, pressure support of 6. So once again, we'll break it down. This is volume control mode SIMV, to be delivered a volume tidal of 650 at a rate of 12 breaths per minute. Titrating FiO2, they have a PEEP of 8 and a pressure support of 6. So this is someone now you might see in someone who's getting weaned to extubate. They're on SIMV mode, their PEEP is lower at 8, they have low pressure support. So this is something you might, like I said, see in someone who's about to get extubated. They're on a bridge to extubation and SVT. So these are some examples of some mechanical ventilation orders you might be able to see in EPIC. It'll help you get a better understanding of where this patient is at with their respiratory support. I hope this topic discussion was helpful in getting a better understanding of actually a rather complex topic. So thank you for taking the time to watch this presentation.